Okay, I think everyone should be in. We're going to get started. Hi, everyone, and thank you for attending Envia Fertility's first patient education webinar. My name is Vicki, and I will be your moderator for this informational session. In 2 short months, I will have been a part of the Envia family for 14 years. I am honored to present to you the speaker of our webinar, Dr. Sigal Klipstein. Dr. Klipstein trained at the University of Chicago for medical school and then completed her residency and fellowship in reproductive medicine at Harvard University. She has extensive experience in treating women over 40 and couples with all types of fertility issues. I look forward to her presentation today.
Hi, thank you everyone. This is our first ever Envia webinar series and patient webinar series. So thank you all for participating. If there are any glitches, I take full responsibility, but hopefully all will be well. So the title of our webinar today is Starting or Restarting Fertility Treatment in a Post-COVID-19 World. And it's something that all of us at Envia have been thinking quite a bit about, and I'm sure all of you on the line as well. Next slide, please. So a little bit about us. As many of you know, our practice has 3 physicians, Dr. Karandi, who initially founded the practice 18 years ago, and Dr. Elizabeth Pushek and myself, Dr. Klipstein. We have 4 locations. Next slide, please. Throughout Chicagoland to make it as convenient as possible for everybody to access care. And just before we get started, I'm going to put up a couple polls as we go through. So if I could have the first poll, please. You should be able to see a poll on your screen. If you could fill that out, we'll give you about 20 or 30 seconds, and then we will post the results of the poll so everybody can see. All right, see what the results of the poll are. Like I said, first ever, so hopefully no technical glitches.
I was waiting for the answers to stop coming in.
Oh, there's, okay, hold on.
Down, sorry.
I want to give everybody a chance to answer.
Yeah, I think everyone's gotten it in, so I'm going to now share the results.
All right, sounds good. So a lot of people thinking about doing treatments, some not quite sure. Thank you very much. All right, let's go to the next slide. All right, so at the very end, I will be answering some questions, and there is a Q&A box if you would put in those questions. I know some of you have already put in questions before we started, and we will try to get to as many as we can at the end of the presentation. Next slide, please. All right, so the goals for today's meeting, first of all, a discussion of starting or restarting fertility treatments. How do we make these decisions, when to start? I will initiate by first looking at a history of COVID-19. Their history isn't very long. As you know, it's only been with us for 6 or 7 months. I'll talk about what we know and also what we don't know about COVID-19 and pregnancy, and very importantly, what we're doing to keep patients safe. And then the next steps for resuming treatment if you're ready to start, if you're thinking about it, whether you're a current patient or a new patient, just thinking about next steps. Next slide, please. All right, so COVID-19 was first described in China in December of 2019. It was probably around a few months before then, but it became recognized as a new virus at that time. And the first cases in the US occurred in January of 2020, and lucky us, the first actually the second and third cases in the US were at our very own Hoffman Estates. It was in a couple, a man and then later his wife who had just returned from China. And they did well, and they were in the hospital for a little bit, and they both recovered fully and went home. As you know, in March, Illinois and Governor Pritzker issued a stay-at-home order, which changed our lives overnight. And since that time, there have now been, unfortunately, over 1.5 million cases and over 100,000 deaths in the US and over 6,000 of those in Illinois alone. So we're certainly living with this. And so when all of this started, and in March, when we realized that this virus was going to be with us and hit us potentially hard, there were some decisions that were made by, next slide please, by the American Society of Reproductive Medicine which is our professional organization. And what they had said after looking at all of the different factors is that U.S. fertility centers should suspend initiation of new treatment cycles, including basically everything we do: ovulation induction, intrauterine inseminations, in vitro fertilization, embryo transfers, and egg freezing. And this at the time was certainly the right decision because we didn't know how hard the virus would hit. We didn't know if we would overwhelm our intensive care units. We didn't know if we had enough ventilators. We didn't want to spread the disease. We didn't know if we'd have enough personal protective equipment to run our show. We didn't know how this was going to affect women who were pregnant or their pregnancies. And so we really just put everything on pause for about 5 weeks, 6 weeks, finished the cycles that were in process, and then waited until more information came through. And I can tell you that during that period, we read voraciously everything that's out there, listened to webinars, went to lectures virtually, and learned as much as we could about COVID so that we could, when we opened up, we could do so safely and with a lot of good information for our patients. Next slide, please. Now, during this period, it seemed like the world was going to end. And for many women and men and couples and individuals going through fertility, it was really very shocking. And so articles came out like this: women falling off the cliff of fertility as pandemic puts treatments on hold. My IVF cycle was canceled due to COVID. And this woman talks about anger, frustration, hopelessness, despair. And certainly, I think it's interesting because as a person going through fertility, there's always this question of, will I get pregnant? Will this be the cycle? What will my future be? When will I have my family? And now with COVID, I feel like we're all experiencing these emotions. You know, is this a virus that's going to infect me or my family? Are people going to die? Is everybody going to get sick? And so to overlay that, in a way, I feel like the whole world is now understanding the experience of the fertility patient, because all of those same frustrations and fears and concerns are coming to be. And so with that, next slide, the big question was, can you still do IVF during the coronavirus pandemic? And initially, we didn't know. And that's why we stopped. But today, after weeks of looking into this and having a lot more information, I can tell you that the answer is yes, we definitely can. At this time, I just wanted to take another poll. If Vicki, if you could put that up. So the question here is, are you currently seeing a fertility specialist? If you could just let us know who you are out there. I know a lot of you have put your names in, but just want to get a sense of who the audience is. We'll give you a minute to answer that, and then we'll look at the poll as we anxiously await your answers.
Just a few more seconds.
No worries.
Down.
I'm very patient.
All right, I'm going to share the results now.
All right. Happy to see a lot of our patients here, so thank you very much for joining us. All right, next slide. So fortunately, after about 5 or 6 weeks and a lot of information and realizing that no, the ERs wouldn't be overwhelmed, and yes, we'd have enough protective equipment, and yes, we have a better understanding of how the virus is transmitted and what the effects might be on pregnancy, the American Society of Reproductive Medicine came out with a second recommendation, which said that with appropriate risk assessment, risk mitigation, consideration of resource availability, and thorough counseling, it is possible to resume providing reproductive services in an environment where COVID-19 exists. And part of this came from the fact that the virus, while really quite prevalent, was not overwhelming the healthcare systems. And to put it into context, currently, we think that no more than 5% of the population has been infected, although that sort of research is ongoing. And the other realization was that COVID, while we were hoping in February and in March that we would just have COVID with us for a month or two, and if we just stuck it out, we'd have a big peak, maybe we'd flatten it and then it would go away. We fairly quickly were humbled and realized that COVID is going to be with us at least for months and maybe till next year, maybe even beyond that. And so we have to realize that we need to function in a world that's, you know, has COVID, and how are we going to manage living our lives with that and getting pregnant and doing all the things one wants to do. So next slide. And so the question becomes then, what are the challenges and how do we inform our patients of exactly what risks they're taking and what the benefits are of starting fertility treatment versus delaying it? So what are the challenges? First of all, We've learned so much in the past several months, and there's so much more to learn. And the knowledge is rapidly emerging. What I knew yesterday is much more than what I knew a week ago, and what I'll know tomorrow, I'm sure, is much more than what I know today. And even now, we have better medications for treatment. The vaccine trials are starting, and we are seeing many fewer hospitalizations. So while people are still getting sick, many fewer of them are getting very sick, and we're learning how to best treat them, which we didn't know early on. And then, of course, some knowledge is not yet knowable. So, for example, we have to keep, I feel like we've been with COVID for forever, my whole life, but really, it hasn't even been with us for a whole 9 months of gestation. So those women that might have gotten infected in the first trimester have babies that are still gestating. They haven't had their babies yet. And so we really don't know how that's going to affect the first trimester. We have a lot of data that's reassuring overall. For example, if we look at the comparison with Zika, we knew fairly early on that there were bad things happening in the uterus, and that the babies were being born with small heads and things like that. We don't see anything like that with this virus, and the way that it infects us, it's a respiratory infection. So we think that it doesn't, cross the placenta. We think that it doesn't affect the pregnancy. Again, we don't have all that information, but it seems to act more like a cold or a flu than something else. We also don't know the long-term impact. So what happens if you get pregnant later in the pregnancy? We do have some pretty good data that the babies tend to do just fine. And of course, we know that children don't seem to be as severely affected as adults. And in fact, many children, we don't know if they're asymptomatic carriers or if they just don't get sick. There have been some children that we know have gotten very sick, but that is a very, very small fraction of all those that have potentially been exposed to the virus. And we know that babies that get sick around the time of delivery tend to do very well. There have been a few babies that we know have gotten the virus. We don't know if they received the virus, if they contracted it while they were in the uterus still, or more likely around the time of delivery if the mom was very, very sick. So next slide. And so we're always balancing things, but the first tenet for me as a physician, the first thing I always think of is how do I do no harm? What do I do to help my patients best achieve their goals without doing anything detrimental? And I think there are two types of harms that you have to balance. On the one hand, there are harms of initiating care, but there is also the opposite harm of delaying care, and you can't look at one without the other. So certainly there are the potential risks to pregnancy, and over time we're understanding what those risks are and how to mitigate them. And there is also, increased exposure to COVID just by virtue of leaving your house and coming to the office and pressing the elevator button or filling gas in your car. Anytime you leave your house and you're not quarantined and isolated, you're going to have risk of exposure. So not anything to do with the treatment, but just by being out and about. There may be limited access if you were to get pregnant to experimental medications or vaccine trials. The American College of OBGYN has been working really hard to include women in these trials because it's very important to know what the effects of all these medications are in pregnancy. Otherwise, you have to extrapolate and you don't always know. And it's better to find out through a controlled study than after the fact. And then also there's emotional distress, fear of the unknown, fear of what will happen to me if I get sick when I am pregnant. But on the other hand, delaying care is not without risk. There is a related decline in fertility that happens with age. There's no denying that. And the longer you wait, the harder it may be for you to get pregnant. There's also the emotional impact of waiting and not knowing when the waiting will end. And this period of sort of unmitigated anticipation to start a cycle. And then we also worry that there may be over time decreased access to care. People may lose insurance, people may lose jobs. Certainly insurance is often linked to jobs. People may have other things going on that may limit their ability to seek care. And so we don't take this lightly, this issue of delaying care. And when the task force made its recommendations, this was one of the considerations. Are we going to wait for years? We're not recommending to women not to get pregnant on their own. So we also are not recommending that they delay fertility treatment because of COVID at this time, given a conversation of the risks and benefits. Next slide. All right, so what do we do know? First of all, we know that most infections are mild and will resolve on their own. 95% of patients will never need to go to the hospital, and those that do end up getting admitted are overwhelmingly ones with pre-existing conditions or older age, and most of our patients are not in that category. So that 5% that end up in the hospital is much lower in our population. Again, when you contract the virus in the second or the third trimester, women and babies overall did well. Data is conflicting whether COVID gets transmitted through pregnancy, and we're learning more and more about this every day, but babies seem to have mild disease, if at all, even if they get it around the time of birth. When you contract COVID in the first trimester, there are concerns, like with any viral infection, any kind of disease that can cause fever. High fever can cause birth defects, and anything that can be done to decrease fever, taking Tylenol and so on, is really important. And it's important to keep an eye on the temperatures when you are pregnant. There is no evidence of birth defects to date, but again, no babies have been born, but there's no ultrasound data that's concerning at this time. And pregnancy doesn't appear to increase the severity of COVID. So with certain diseases like the flu, if you were to get the flu while pregnant, on average, you'll be sicker than someone who isn't pregnant and gets the flu. But with COVID, it seems like, yes, there are some women that get very sick with COVID, but they're not more likely to get very sick if they're pregnant. So that's somewhat reassuring as well. Next slide. All right, I get asked a lot about travel. Is it a good idea? What to do? You know, we're tired of being cooped up at home. There are lots of places to go, people to see, but it does increase your risk of infection. Certainly, it's more difficult to socially distance when you're in an airport or on a plane or with public transportation, at the TSA lines. And also, you have to consider that maybe the place you're going might have higher rates of COVID. In Illinois, fortunately, the rates are going down, the hospitalizations are going down, the new infections are going down. That is not the case everywhere in the country. Currently, there are hotspots, Texas, Florida, and so you have to think about not just where you are, but where you might be. And then you're exposing yourself to more people. There are loosening of local restrictions throughout the country, but I think it's important to know that loosening of restrictions does not equal that it's safe to travel. This is a risk-benefit discussion and an economic discussion, but we have to be, I think, a little bit more cautious when we're looking at women who are pregnant, trying to get pregnant, partners of women, and potential infection risk. So I think, you know, travel should be minimized. Of course, there are emergencies, there are reasons why we might have to travel, but as much as we can, it's important to self-quarantine when possible. Next. All right, so what's important is striking a balance. I don't want anyone to walk away from this saying that the willingness of physicians to offer care means that there's no risk, but everything we do has risk. Getting pregnant has a risk. Not getting pregnant, obviously, you know, can have a risk as well. Overall, the preliminary pregnancy data is reassuring. Risk appetite and ability to accept the unknown is different among individuals, and so it's important to know yourself and know where you are on the spectrum of I want absolutely no risk, or I'm willing to take a lot of risk to achieve the things that are important to me. And so you have to understand, first of all, what's known and what's not known, and that is changing every day. Ask lots of questions. You know, I and my colleagues at INVIA are really very open and happy to answer questions, and in fact, everybody that comes through to do a fertility treatment cycle meets with us one-on-one individually to go through a consent form, to go through what's known and what's not known, and to make sure that all your questions are answered so that you can make a decision from a very educated, knowledgeable place. And just know that knowledge will increase over time, but yet fertility decisions in today's day and age must be made in an age of uncertainty. Yes, uncertainty will decrease, but and every day is better, but we don't know when we'll have full knowledge, and we certainly will not have full knowledge for at least a number of months, and maybe it'll be years before we fully understand the implications of this disease. And hopefully it'll be much more reassuring than we feared at first, and things will be better than expected, but we don't know yet. We don't know how it'll affect pregnancy and babies and so on. So hopefully we'll learn lots of good things, but we need a little time to get that information. I wish we could have a crystal ball, but time is our crystal ball. Next. And then it's really important to keep in mind that this is a difficult time for everybody, and you need to be good to yourself and take care of your emotional needs. Reach out to us with concerns. There's certainly a lot of resources out there. A mental health consultation just to talk through concerns is certainly helpful. You could consider going to there's some places where you can get links. We have lots of resources available for you, but the American Society of Reproductive Medicine has a whole professional group that just has a membership of all the mental health professionals, and they have a resource page, which is great. Resolve is the National Infertility Association, which is both a resource, offers resource and help and advocacy for infertile men and women and couples, and they have support groups and discussion groups, and these used to be in person, but Everything's moved a lot more virtually, and so fortunately they're very easy to access, and you can go to their website and punch in your zip code and find a support group near you. And I encourage everybody to consider these options. And next, please. Fertility treatment is always complex. There are lots of things to think about: eggs and sperm and the uterus and testing and ultrasounds and injections and pills and concerns. And so we know that there is that. And what we do every day is to try and ease that burden and make it as easy as possible to go through what is a complex series of procedures in order to get to the end goal. And COVID, which you can see here on the left, they make the virus look so pretty, and yet it's so evil. But anyways, but COVID just adds another layer of complexity. And so I think when we think about what's your blood type, what's your hormone levels, when do you need your ultrasounds, we're also going to have to think about COVID and how that's going to affect you, same way as we want to check that you're immune to chickenpox and things like that. We're going to talk about COVID status and how we can protect you. So it's just one more thing to consider, and over time it will become the norm until hopefully it goes away and we don't have to think about it anymore. Next, please. And so what are we doing in the here and now to protect our patients? So first of all, in that 6 weeks that we were closed, we had a lot of ongoing conversations and change in protocols and really a long and hard thinking about how we can change everything in our system to protect all of our patients. So everybody now is getting temperature checks and screening questions prior to entering the office. People are socially distanced. We're asking all of our patients to wear masks, all of our staff, everybody who sees the patient and doesn't see the patient, everybody in our office is wearing masks. We're spacing out appointment times. We're asking people to wait in the car. We're calling them up. You'll see there are X's in our waiting room there where you can't sit. We have forbidden seats because we want to make sure that everybody's spaced out. And the office, we try to keep it in what is usually a busy, vibrant office, so we try to keep as empty as possible. And we ask only patients to come to our appointments. Now, I understand that everybody's a patient and the partners are patients and the support people are really important, but we want to do everything we can to mitigate the risks and ask that only those people undergoing procedures come in. Of course, for things like egg retrievals, we need both of you, we need the partner, we need the designated driver, we understand, and we will have more than one person in the office, but whatever we can do to limit those visits, we do. It's hard for all of us. We want everybody to come. We want to be a welcoming environment. We just have to think about all of our safety during this very difficult time, and hopefully we'll be able to go to normal very soon. Next. One of the important strategies that we included and really overnight moved to is telemedicine. And we realize that there's a whole lot we can do that way. And we offer all of our patients video conferencing for any appointment that doesn't require an office visit. Necessary forms can be signed electronically, remotely, nurse consults, learning how to take your medications, answering of questions, all of that can be done remotely, and that's been working really well. We're using Zoom. It's working nicely for us. I wish we could do ultrasounds remotely, but we haven't been able to do that yet. There are technologies actually under development where women can do their own ultrasounds, interestingly, but we're not quite there yet. And so there's also, with that, we've expanded our access to physician consults, and we're trying to increase our hours and make it as easy as possible to get in for an appointment so that we can at least chat. Of course, a lot of these things will have to be done eventually in the office, but for whatever appointments we can, it's nice. And what's also nice is that you and your partner may not be in the same place, but you can be in two separate places, and we can all meet and we can be virtually together, and that works quite well. Next slide, please. All right, so what are the next steps? So for our current patients, we have a nice portal system, and you can call us, you can send us a portal, you can email the nurses, and set up a telemedicine consult with your doctor to talk about next steps and when you want to start and what the options are and how you can protect yourself. Some people are choosing to come in and do an IVF cycle but freeze their embryos and wait a little bit. Some people want to get going. We'll talk with you about all the risks and benefits for your particular situation, and we're happy to do that anytime. For new patients, there are lots of ways to find us. You can call us, you can email us, you can find us on our website. And what I recommend is set up an initial visit. We can do that by telemedicine. You don't have to come into the office. Everything that can be done remotely will be done. And we can review your records and go over what got you to this point, what the next steps might be. If you're not ready to start, we can make a plan for when you are ready to start. If you are ready to start, we can get you going. But we want to do this as safely as possible, and telemedicine is a great option. So with that, I will place all of our information, our email, our all of our links, Facebook, Instagram, lots of ways to find us and follow us. We do have a blog on our website, so if you have questions, you can go there and type in your questions and you'll find lots of information. And I think I'll turn it over to Vicki for the questions.
Okay. We've had a lot come in, so I'm just going to try to get to as many as we can. First one, would starting fertility treatments put me at a higher risk of COVID-19?
No. So I think what's important, first of all, to know is that a lot of our patients are coming back and starting treatments, and we're fully functioning and open for business. Plenty of people are starting treatment, and every week we're seeing more and more people coming to restart or start their cycles or to start the ones that were delayed. In terms of COVID, no, women going through fertility treatment are not more susceptible, and there's nothing that we do on our end that would increase your risk. None of the fertility treatments, none of the procedures would increase your risk of COVID.
All right, next one is a two-parter. What would happen in the future if there were another wave? Would your fertility process be put on hold?
Yeah. So we don't know. We are doing everything we can to limit the infection risk and to protect our patients and to be able to function even with COVID circulating in our communities. If there's another shutdown order and a lockdown, if we're prohibited from functioning, then yes, there is that possibility. We hope not. There is talk of a second wave in the fall. We don't know if that will happen or not. We have many systems in place to mitigate the risk. And what I tell everybody is that I cannot promise that that won't happen, but we are doing everything we can to move forward. If it's not safe to move forward, we won't move forward. Our number one priority is patient safety. But we know a lot more now than we knew back in March when we paused all treatments, and I'm very hopeful that that won't happen again. But this virus has been very humbling and none of us know. So we will do what we need to protect you and protect your pregnancy.
Okay. What do medical experts know about COVID-19 and miscarriage risk?
Yeah, it's a really interesting question because miscarriages happen, and miscarriages in the first trimester are, of course, that information we are starting to gather. But again, there aren't that many women who have had COVID and have miscarried. There have been a few just isolated case reports. Overall, it's been reassuring, but we just don't know if there's a higher miscarriage rate in women that contract COVID in the first trimester. So that's another crystal ball question I wish we knew. We know that there are women, many women who contract COVID and many mild cases, some women that don't even know that they had COVID and they continue their pregnancies just fine. 20% of women miscarry at baseline. So just of all women who get pregnant, about 20% will miscarry. And so when there's a miscarriage in someone who has COVID, we need a lot more time and a lot more data to know if that miscarriage was related to COVID or related to some issue with the pregnancy, or would have miscarried anyways. And so right now we don't see a huge uptick in miscarriages, but we don't have enough data to say that with certainty.
Okay. What are the impacts of COVID-19 on the fetus during development, and are there risks to the mother's health if exposed to COVID?
Right, so I think the risks to the mother's health are the same risks for anyone being exposed to COVID. And again, most women will have a mild infection, some will get a little sicker, very few will require hospitalization, and even fewer will require to be placed on a ventilator, very, very small fraction of young adults in the age group that you're trying to get pregnant. The effects on the fetus, again, it looks like the closer you are to delivery, the lesser the effects, as far as we know, but only because we have more information. What the effects are earlier in the pregnancy, again, we don't see negative effects right now, but we just don't have full information. So stay tuned. Hopefully the webinar we do on this topic in 6 months will have a lot more information.
Okay, here's an important one. Are new patients and cycles allowed to begin?
Yes, most definitely. We are cycling and we are ready to go for all types of cycles, inseminations, IVF, embryo transfers. Yes, we are fully open and ready for business. And like I said, with all the precautions in place, but yes, very carefully, very cautiously, and with a lot of social distancing, but we are indeed starting cycles.
Okay, we've had a couple questions. I'm just going to kind of group them together. essentially asking, when can I begin prepping for my frozen embryo transfer?
Yeah, so you can start now. What I recommend if people have questions about timing is to just call our office and set up an appointment either with the nurses or with one of the doctors. We are trying to space things out, but we are opening, more hours and more days. And so, we're open every day for in vitro fertilization procedures, but we are trying to space things and limit how many people start at any given time. So if you're thinking about getting started, I would say just set up a consultation and we will get you in the queue and get started as soon as you are ready and we can accommodate.
I have one that came in. Can you please discuss how fevers from COVID or in general affect first trimester pregnancy? Is it all fevers or only fevers over a specific temperature?
Yeah, good question. So mild fevers don't seem to affect pregnancy, but fevers, when you start getting into 103, 104 or higher, then we worry. And this is really more a first trimester risk of birth defects. But whether the fever is from COVID or from a bacterial infection or from the flu or anything else, these work the same. And so there are lots of reasons why you might get fever in the first trimester. And so what's important really is to take Tylenol and drink plenty of fluids and do all the things you can do to reduce those fevers. It's not common to have very high fevers in the first trimester, so that's reassuring. And most people with COVID don't have very high fevers. Some do, and that's something to consider. Really the best thing to do is to protect yourself and quarantine yourself as much as possible. Try to avoid infection. Vicki, I'm ready for the...
Another one, is it advisable to start fertility treatments when you have an underlying condition that can increase COVID complications such as asthma?
Yeah, it's interesting. There have been a lot of studies about what underlying conditions increase your risk. So things like asthma and smoking, which you would think because it's a respiratory infection increase your risk, actually don't increase your risk of getting sicker than someone who doesn't have these conditions. Things like hypertension, obesity, diabetes, these do increase your risk. And so there's some things that are underlying conditions that aren't really as concerning. And again, this is why I say that the COVID is somewhat humbling, because all the things we knew about respiratory infections don't seem to hold in the same way with COVID. So yes, you can start with asthma as long as it's well controlled. And this is something that you'd want to talk with your physician, perhaps not only your fertility physician, but also your internal medicine or your pulmonologist, and come up with a plan of how to best move forward with an underlying condition. Certainly you want to make sure that whatever the underlying condition, diabetes, high blood pressure, is under good control before you start. But that's true for pregnancy in general.
Okay. I have one. Do we recommend once a person is pregnant that they self-quarantine strictly at home for either the first trimester, the entire pregnancy? And she's asking, specifically, like, should she only go to the grocery store? Should she not leave at all?
Yeah, I mean, look, I think we can't be at home forever. On the other hand, everything you do to limit your interactions, to stay at home as much as possible, to not be exposed to people who might have infections. If you do leave, to wear masks, to wear gloves, to wash your hands frequently, to not touch your face, all of those things that we now know are precautionary will decrease your risk. And so I do think that whatever we can do to limit exposure is important, particularly during fertility treatment and early in pregnancy, because those are the periods of time where we just don't have a lot of information yet. Obviously better not to get COVID than to get. Having said that, people need to go out, people need to work, people need to shop. You can't hibernate forever. As we emerge and do more and more, hopefully we won't see a resurgence of cases, but I think we're all being much more careful. I mean, who would have thought 6 months ago that we'd be seeing people in the parks with masks? Is sort of unheard of, and now we're all doing all these wonderful things to help protect one another. So yes, I think as much quarantine as you can, but within reason.
Would you give the same answer for the question of quarantining before starting treatment and during treatment?
I think it's really important to not be sick while you're going through the treatment. Obviously, if you get very sick and you can't come to your visits, and you have to cancel a cycle because of a fever, you certainly wouldn't want anyone to get pregnant with a high fever or active COVID. So yes, I think that it's important in that period when you're starting treatment and until you're pregnant to be very careful. And that might be a particularly fragile and important window of time to be very careful.
Okay, here's one near and dear to my heart. What effect does COVID have as far as egg, sperm donors, and surrogates? Is it more difficult to find donors and surrogates? And would you recommend using someone that doesn't require air travel?
So this is a good question. So Vicky didn't perhaps fully disclose, but she's our third-party coordinator, and she coordinates all of our egg and sperm and surrogacy cycles. And so it is a very important question. So we, like I said, when we stopped everything, we stopped recruiting our egg donors. We use sperm banks for sperm donors. What we do know is that COVID does not appear to be transmitted through egg or sperm or embryo. So I think we're pretty safe there. So if you were to order a sperm from a sperm bank, or use a frozen egg or an egg donor, I would not be overly concerned that you could contract COVID or that the egg or sperm would have any effects from COVID. In terms of surrogacy, again, there's an effect, if there's an infection during pregnancy. So I think you need to be very clear with whoever you work with and your surrogate or your gestational carrier to make sure that you're on the same page in terms of your kind of risk aversion. So if the gestational carrier wants to go, out every night to groups of 100 people, then you're really worried about that. That might not be the right person for you. So I think that conversation has to happen really early on in the process. In terms of surrogates, gestational carriers, the travel, I think this is a little bit more difficult because air travel has been restricted for a long time. Now that it's a little bit more open, there is risk of becoming sick just from more exposure, and so we have to think long and hard about that. Certainly if the gestational carrier is within driving distance, I would feel a little bit safer with that. The other issue is international gestational carriers, and that's a much bigger issue because as borders have closed, there have been situations where the intended parents and the babies couldn't be reunited, or the parents couldn't travel for the delivery because of closed borders. So that's a huge issue, and that I would be very hesitant to start right now. But local domestic cycles are ongoing, and they can be coordinated.
Okay. What are you doing to protect your staff? Are they being tested for COVID as well?
Yes. So everybody is getting temperature checks before they come in and when they come into the office. Hand washing, staff members come in, get their temperature checked, wash their hands, put on, they come in with their mask, keep their mask on at all times unless, except for when they're eating. And so we're doing everything we can to protect our staff. We're socially distancing our staff as well. And we have 4 offices, and everybody likes to sort of be together because we're a very social group, but we're working really hard to leave people in different offices. Some of our staff is working from home that can. And so we're doing everything we possibly can to protect our staff as well. Fortunately, in this day and age with remote work and access to our online medical record, we're completely digital and electronic. It's a little bit easier than it would have been. I can't even imagine what would have happened 10 or 20 years ago if this had happened. We really would not have been able to function as successfully as we are today.
Another one just came in. Are you testing your patients for COVID-19?
So this is a really interesting question, and it's being debated from the upper levels of task forces to the day-to-day workings at every fertility clinic. The problem with testing is that the testing is not completely accurate, so a lot of people that might be positive are not testing positive. The other issue is, when do you test? So if you test someone at the start of a cycle, they might test negative at the start of a cycle but be positive later on. You can't test everybody every day, right? And so that becomes an issue. But we are testing patients. We're starting to test patients at the beginning of their IVF cycle. This is something we're going to be instituting soon. We're waiting for guidelines, and we will follow all the guidelines from the FDA and the CDC and our task force and do what's appropriate, and of course follow them and exceed them. And so I guess the short answer is yes, we are starting to test, and the long answer is we don't know if testing is going to be, testing is helpful because obviously if we know that someone has COVID, then we can act on that. But what we don't know is when to test and how often and under what circumstances and which test, and waiting for the results to come back. So yes, that's an ongoing discussion, and we're doing everything we can to be as safe as possible. And one part of that is testing as a strategy. But I think even more important is all the other things, the masks and the washing of the hands and staying far apart. Because if you do all of those things, you're going to be much less likely to get COVID. And so everything together is protecting all of us.
Okay. These are unprecedented and stressful times. What is known about stress and its effect on fertility and pregnancy?
Yes, so stress certainly is not a good thing, and whatever we can do to mitigate stress is important. I think, I get asked this question a lot, and the problem is that the more you stress about stress, the more stressed you'll be, and the worse it'll be for you. And so to add sort of a worry that if I'm stressed, then it'll decrease my outcome is sort of counterproductive. Having said that, anything that you can do to decrease stress is important, whether that means talking to your loved ones or your friends or your family or your therapists, or going to these online support groups or using an app that's a relaxation app. Yes, there's some studies that show that there is an effect of stress on pregnancy and miscarriage rates. The effect is not a strong effect, and everybody going through fertility, I would expect, is stressed to some extent. It's sort of impossible to say, well, I don't really care what happens, I'll just go through it and it'll be okay. I mean, so that's not the reality. The reality is that stress is with us and it's part of the process. But anything we can do to decrease stress is important, and we have lots of strategies for that. And I encourage everybody to do what's right for them in order to decrease their stress level to the extent possible.
I had one that came, well, a couple, so I'm going to try to rephrase them. Essentially asking, where are our numbers? Are patients cycling right now? Are we, kind of as busy as we were prior to COVID, or are more patients being still waiting, essentially?
Yeah, busier, because we had a whole 6-week period where people who were just about ready to start had to delay. And so on top of that, people that were planning on starting anyways, currently we're seeing, so we're actually quite busy, but working really hard to spread everyone out. And so every week more and more people are coming and wanting treatment, and we're doing everything we can to keep up and to get everybody that needs treatment through the door. And certainly if people have more urgent reasons to come through sooner, then we will definitely take that into consideration, do everything we can to see everybody and take care of everybody in the best way possible.
Okay. I had another question about someone with she's a diabetic type 1 that's very well controlled. Do you recommend she wait until there's a vaccine in place, or would she be okay to get started?
Yeah, it's a good question. Again, I think this falls into the risk-benefit analysis. What are your actual risks? What are the benefits of starting versus the benefits of waiting? A lot of this has to do with your ovarian reserve and your personal circumstances and whether you have time to wait. Sometimes we might recommend starting a cycle. Let's say you're ready to do in vitro, but you don't have to do the transfer and get pregnant right away. You can freeze those embryos for later. So it just really depends on personal circumstances, and so I would recommend a one-on-one consultation to discuss those issues. It's never an easy answer.
I just had one. Hang on. Oh, I'm not sure if this is one you can answer, but the question is, when there is a vaccine, will pregnant women be able to get it?
We don't know. And that's why I say it's so important to include pregnant women in vaccine trials, because we'd really like to know under a controlled environment what the effect is. I would think it would be as important, if not more important, for women who are pregnant to get the vaccine to protect themselves in their pregnancies. So my sense is that likely, yes, that will depend on what the vaccine is and how it's formulated and whether it's, has any risk of exacerbating disease if you were to get infected. So we don't know yet, but I would hope that pregnant women could get the vaccine. But that's one of the things I discuss as part of my consent process, is that we just don't know, and you might be excluded certainly from the trials. Maybe once the vaccine is out in for public consumption, you would be able to access it, but you may not be able to access it under a clinical trial.
Okay. I have one. My husband is a essential employee and has not been quarantined at all since this started. Would you recommend he freeze a sample now while we know that he's not displaying any symptoms, or would you think it's safe to just proceed with treatment as is and have him produce at the time?
Yeah, I mean, I think it's always an option to freeze eggs or sperm. As COVID is not transmitted through sperm, I think it's reasonable um, to go ahead and use a sample when you're ready to do it for the fertility treatment. You don't necessarily need to freeze the sperm sample in advance unless there's some other reason why you might want to freeze the sample.
Okay, I have one I want to share. It's not a question. It is a patient of ours who wanted to share. I was pregnant during COVID-19 and gave birth to a healthy baby boy during the peak of the wave.
Oh,
Thank you to the NVS staff, especially Dr. Klipstein, for all the care and support. Best of luck to all the to-be moms. Have faith. It's not easy, but it can be done.
thank you. I'm glad. That's wonderful. Congratulations. And I will find out who you are and reach out to you personally. But thank you. I think it's really reassuring. And in the end, I've gotten a lot of questions from patients who are close to delivery. And certainly I did a couple of months ago when things were at the peak, really worried about going to the hospital. But really, you have no choice. And the hospitals have lots of systems in place and special units where the patients with COVID go separate from everybody else, and testing and so on. And so a lot of things to do to protect women, especially women who are going to deliver. So I don't think, you have no choice. The baby has to come out, but thank you so much for those reassuring words, and congratulations.
I have a couple people have asked, when will the clinical trials resume?
Yes, so we do have some clinical trials ongoing that are national. When the recommendation was made to close all fertility care, those trials were put on hold, and we're still awaiting restarting. So we're planning on restarting. We're doing all the pre-testing to start the trials, and some of these have coverage of the majority of the cost of an IVF treatment. So they're really good studies, but we have to wait until the study coordinators, which are like I said, it's a national study. We're not the organizers of the study. It's run by one of the pharmaceutical companies. As soon as they give us the green light, we're ready and waiting to go. So we are all set up and hopefully very soon.
I'm kind of trying to wrap it up. This one says, if we are still in the beginning stages of exploring and or starting treatment, if we need to complete a semen panel, how far in advance should we do it? So I think you kind of covered that one.
Yeah, I think that's always important to do as one of the first parts of the fertility evaluation process. And sometimes people aren't ready to start treatment quite yet, but it's important to check the semen analysis, maybe the ovarian reserve, and then at least you kind of know, is there some issue that's identifiable, or can I hold off a little bit? Things look overall okay. So I don't think it's a bad idea to just do that. And even if you're not quite ready to start, at least have a sense of the urgency, because that will give you a lot of information.
Okay, I think that's pretty much it. Some of these questions are going to get a personal response as they're personalized. So if anyone can think of any other questions that they want to share, definitely send it to the email address on your screen. We do have one more poll question that we would like to share. Let me bring it up. If you could review the question on there and give us a response, that'd be great.
And while you're answering, I just wanted to thank everybody for your time and your attention. And this has been fun. And we look forward to doing many more of these. And we will send out a poll later to see what topics you are interested in hearing more about. So appreciate.
Okay, it looks like they've stopped answering, so I'm going to share the results with everybody. Good. This is good. So
all right. Good. So we've done our job.
Yes. So thank you, Dr. Klipstein, for sharing this information with us. Thank you so much to everyone who attended this webinar and for sharing your responses with us. Please check our website for dates of future webinars. If you have, like I said, a question that we didn't get to, or if you later on think of something you want to ask after this is ended, send it to the email on your screen, info@enviafertility.com. And everyone stay safe and healthy.
Bye-bye, everyone.
Bye.